Hello and welcome back to Advanced Human Gross Anatomy. Today we will be doing our first dissection. We'll call this an introduction to the thorax. And I'm excited for you guys to start digging in a little bit today. The first things we're going to talk about here is anatomical position. This is a way that we can standardize directional terms when we talk about the body. So the position of anatomical position is that you're standing tall and erect, your feet are facing forward, your palms are facing forward, your face is facing forward, your arms are out like this. This is an anatomical position. So when we talk about directional terms, we're going to talk about them in relation to each other as they compare to this anatomical position. So we'll use words like superior and posterior. Superior is being above, inferior. We'll call superior and inferior being below. But again, that's in relation to something else. If something is inferior to it, there is something that's superior to that structure as well. We'll talk about anterior in the front, posterior in the back. We'll use words like medial and lateral, superficial and deep, and as we go through. But this anatomical position is the starting point for how we discuss where one structure is in relation to another. One of the things we see in this slide too is the planes. We are three-dimensional, so there are three planes here. This one that's cutting this way is cutting in the sagittal plane, which means it's going to create a left and a right side. This happens to be a mid-sagittal plane cutting straight through the midline of the body. It could also be perisagittal, kind of over to one side. We could also talk about these terms in relating to the arm or the leg. If you're going to make a sagittal cut, it's going to be along this plane, creating a left and a right side. Another plane here is called the frontal plane. This one is this box here. Another name for frontal plane is also called the coronal plane, if it helps to think about putting a crown on, where it would go on top of your head. Separating front and back, anterior and posterior, would be the frontal plane. And then the transverse plane, this third one here, kind of as a sheet cutting through the midline of the body here, is going to create a top and a bottom, a superior and an inferior portion. But like I said, you could make these kinds of planes anywhere in the body. They don't need to be in midline as these sections are in this slide. We'll move on to the thorax here. The posterior wall of the thorax is the vertebrae, the vertebral column. And what we see here are vertebrae stacked one on top of another to create an almost rigid center beam for the body to have its support from. It's not rigid. It does allow a vast amount of movement, but it is very stable. It's very structurally stable. So we'll talk a little bit about some of the structures here. Let's see. Like I said, it can be moved when it needs to, but it can also be very fixed and rigid, which allows it to be very versatile with how we move and contract our bodies. When we see a particular vertebrae here, this happens to be a thoracic vertebrae because we are talking about the thoracic cavity today. There is a body of the vertebrae, which is this front portion here. Here's an anterior portion. Here's a posterior view of this vertebrae. We'll look at the thoracic one here. So the anterior portion, posterior. The body is what the vertebrae sit on. So if we look back at this, you can see all the bodies of the vertebrae stacked one on top of another. Okay, let's see, go back to this. There's the pedicle, which is a connection of the body to a long spike here on the sides called the transverse process. This will be, we'll talk about the transverse process here right away, might as well. This is a spot where muscles and ligaments attach to the transverse processes, and they allow for the stability during movement. So these are the transverse process coming from there. Between the body and the transverse process is the pedicle. You might have heard this term if you're talking to a surgeon who used a pedicle screw, if they're using some type of fixation device to hold vertebrae together to fuse them. between the transverse process and what's called the spinous process is called the lamina. This is a portion that's often removed in surgeries. Um, it would be a posterior support to the spinal cord on the backside here. And then here's the spinous process. This is very similar to the to the transverse process because it is, again, an attachment of muscles and ligaments to adjacent vertebrae that allow for stability during movement. And as we continue the circle here, here's the other pedicle, here's the other transverse process, the other lamina, and then back to the body. So that would be, that whole thing creates the vertebral foramen. This is where the spinal cord would sit within each vertebrae. Now, if you put them all together, stack them one on top of another, it will make a vertebral column. I'm sorry, it will take a vertebral canal, which is where the spinal cord will go through all of the vertebrae. But if we're looking just at one like this, it's called the vertebral foramen. Now, if we see on the side here, there's a process sticking straight up here and then straight down here. These are the articular processes. And what happens here is this is where the joints, the vertebrae above and below will attach. If we look back at maybe this one, you can see how the vertebrae above will attach to the top, the vertebrae below will attach to the bottom, and then they can just attach themselves to each other like that all the way up and down the thoracic spine to get their stability. You can see how the front articular process is facing posteriorly, and you can see how the inferior articular process is facing anteriorly. They alternate that way to receive then the inferior articular facet of the vertebrae above and the superior articular facet of the vertebrae below. And that's how they'll stack one on top of another, creating this continuation of the vertebral foramen into the vertebral canal. The intervertebral discs are shown here. These are fibrocartilage discs, these pads that go between each of the bodies of the vertebrae. They allow for the vertebrae to have a bit of a cushion, so when you jump or land and gravity is pushing down on you, these are what will help absorb that blow between each of the vertebrae in the spine down to the sacrum. And they're fibrocartilage. Now, they can be a bit troublesome if there's a significant, for instance, an anterior force between the bodies of these vertebrae. This fibrocartilage disc will start to push backwards into that vertebral canal, and that's where the spinal cord is. And you can see all these little holes here, the intervertebral foramen, where those bones come together where the vertebrae above meets the vertebrae below at the articular process. They make a little hole right here on the sides. You can see all the holes all the way down. This is where the spinal nerve roots will exit the spinal cord and the spinal column and then leave to go to their designated areas. And so if the disc is pushing backwards, it might take up some space in that intervertebral foramen, and that can cause a pinched nerve, or maybe you call this a herniated. The disc can herniate, causing a pinched nerve. Now, there's lots of language here that might be unhelpful. There's all sorts of descriptors people have used over the years to help describe what that means. Some of the more unhelpful ones are, I think of the disc as a jelly donut. That just doesn't work that way. People talk about slipped discs. The disc can't slip. I think when patients hear things like that, they think about a disc just slipping out and going into a different part of your anatomy. That's not the way this works, but that would be the area anyway of what we're talking about, is the disc here. That's the posterior thoracic cavity. If we look more towards the anterior portion and lateral portion, we talk about the rib cage. So the rib cage comes from the vertebrae, where it will attach to the body of the vertebrae as well as that transverse process as it hooks around. And then the first 7 will directly attach right to the sternum itself. So the sternum, we think about as 3 different parts. There is a manubrium up here on the top portion. There is a body which is the main portion of the sternum here, and then there is the xiphoid process. The xiphoid process starts out in your development as mostly hyaline cartilage. It does ossify as we age, and it's often a site of just a place on the geography where we can get a landmark before we do CPR, cardiopulmonary resuscitation. So you'll find the xiphoid process where the rib cage comes together at the base. You'll put 2 fingers up above that and then place your palm above that, which should be right on the body of the sternum, and then compressing the rib cage to actively, mechanically, manually get the heart to actually pump the blood. So that's what we're talking about there. But the organs inside the thoracic cavity are protected by this whole thing as a unit, from the posterior aspect to the lateral sides to the anterior. So this whole thoracic cavity is a bit of a cage to help protect what's inside of it. Now, if we talk about the ribs themselves, let's go to this one here. The ribs have a common anatomy to each other. There's what's called a head, which is what actually attaches to the vertebrae itself. There's a neck, a thinner portion here. The head and the neck are just the distended portion. The end is the head. Coming off of the head would be the neck. And then there's this little bump on the side. Here you can see it better as it's kind of sitting. So it would attach to the body of the vertebrae, both above and below here, and wrap around, and then here's a tubercle where that transverse process is going to attach as well. So it's got actually 3 points of attachment: the body of the vertebrae above and below, and the transverse process of that level before it will come around. Now you can see on this slide here where it makes this angle. There's a sharpness to this angle as it comes around, and then the rest of it's really just called the body of the vertebrae, of the rib as it comes around, and where it will attach towards the front in the sternum. Now you notice that they don't actually attach directly to the sternum. The connection here is hyaline cartilage. So between the end of the rib and the sternum at the anterior portion, you'll see this portion here is cartilage. So on the body, there isn't actually a bone-to-bone attachment of the ribs to the sternum, which is what partly gives it its elasticity, its ability to articulate as it moves up and down, out and back. You think of the rib cage really valuable as we breathe. As you inhale, as you decrease the pressure in the thoracic cavity as compared to the atmospheric pressure, as the diaphragm contracts down, it creates more space within the thoracic cavity, and that would allow air to come in to the lungs, into the alveoli for gas exchange. As the volume of the rib cage decreases, as the diaphragm comes back up into the thoracic cavity and the pressure increases in the thoracic cavity in relation to the atmospheric pressure, air will be pushed out of the lungs. And so that bucket handle kind of movement as the ribs, you can see here, as the ribs kind of inhale, the ribs kind of pivot up. As you exhale, they'll come back down, and that's how we breathe. Partly. We'll get more into that later on. Now, you can see the first 7 ribs we call true ribs because they actually have an attachment to the vertebrae, to the sternum itself. Ribs 8, 9, and 10, actually their hyaline cartilage comes up into the hyaline cartilage of the 7th rib. So they attach to the 7th rib, which attaches to the sternum. So we call those false ribs. The first 7 we'll call true ribs. Also, false ribs are 11 and 12. These they have a special name, though. Floating ribs. 11 and 12 don't have an actual attachment to the anterior thoracic wall. They just are coming around partway through. So 1 through 7, direct attachments to the sternum. 8, 9, and 10. 8, 9, 10, and 11 and 12 are false ribs, but 8, 9, and 10 actually do come up and attach to the sternum via the hyaline cartilage of the 7th rib, and 11 and 12 are floating ribs outside. Okay, should we talk about the sternum? The sternum the clavicle. We talked about the sternum already. The clavicle is the attachment. Basically, if you think of it this way, it's the only bone-to-bone attachment we have of our shoulder blade and arm, our whole upper extremity and shoulder girdle, to the skeletal system. So it comes from this clavicular notch right here on the manubrium of the sternum, and it comes over to attach to this portion of the shoulder blade, the scapula, called the acromion process. And so it has two portions here. There is the SC joint, the sternoclavicular joint, and then the AC joint, the acromioclavicular joint. You may have heard of somebody, or it may have happened to you, where you've separated your shoulder. That's kind of a slang, a vernacular for separating this AC joint, where that connection gets disrupted. The ligaments there start to lose their integrity, excuse me, typically by a trauma. And then the clavicle pretty much stays put, but the scapula and the humerus will drop. They'll kind of fall inferiorly, making it look like that end of the scapula is raised way up, but in reality, the scapula and humerus have dropped. So the clavicle stays put, and everything else falls. Because it is the only bone-to-bone connection in our body of the upper extremity to the skeletal system, it is the most frequently broken bone in the body. I got 10 cents off a caribou once because that was one of the quiz questions. So there you go. Anatomy can help pay for your coffee in the future, maybe. And like I said, because it's the only bone connection to the shoulder blade, it's kind of a big deal. Looking better at the shoulder blade, a couple things here. There's this spine of the scapula. This is a right shoulder blade, a right scapula from the posterior aspect here. I know it looks like it's coming from the anterior side, so it's the right shoulder blade, but this skeleton should really be facing the other direction to get this view. So here's a medial border of the scapula, and a lateral or axillary border of the scapula. Superior angle will be up here. This is the spine of the scapula as it comes up and around. We'll learn more about the scapula specifically when we talk about joints of the upper extremities. But at the end of the spine of the scapula is this distended portion, this bony part, kind of a square-looking structure here called the acromion process. If we go back to this picture, that's actually this portion here where the clavicle attaches before it ends up at the manubrium of the sternum. So that portion is where the clavicle will attach and come anteriorly in this direction towards the scapula, or towards the sternum. Another portion on the shoulder blade is the coracoid process. Coracoid process is this portion here. Again, it's coming more from the front. Here you can see it hooking towards the plane of the screen, coming towards you and then making its lateral angle over. A good muscle attachment to a couple important muscles, one being the pectoralis minor that we'll talk about later today, attaches to the coracoid process of the scapula. So that's where that is. Let's move on now and talk about skin. Because we will be taking the skin off, it's important to kind of get some bearings about what we're looking at and how to separate some of these tissues together. This is going to be pretty much consistent throughout any part of the body where we deal with skin. So we'll just talk about a baseline here of what these layers are. The first layer outside is called the epidermis. It's the outermost layer. It is epithelial tissue, specifically stratified squamous epithelial tissue is what this outer layer is. It's a good protective barrier. It won't allow things in. It won't let things out. It's a nice sealant to the body, if you will. One interesting thing is that it doesn't have blood vessels. If you scratch or scrape yourself through the into the epidermis, it's just a scratch. It won't actually bleed. If it does bleed, that means you went through the epidermis into the dermis, which is where the blood vessels are. But back to the epidermis, no blood vessels, but there are a few pain receptors, but there is some nerve receptors at the epidermis. Now, deep to the epidermis, this is a beautiful dissection, by the way. I challenge any of you to
mimic this in lab. But this dermis is just deep to the epidermis here, this is now where you're going to have the blood vessels. Okay, so deep to the epidermis. If you did get a cut that did start to bleed, you've gone through epidermis, now into the dermis. Any of the nutrition coming from that the epidermis gets comes from the dermis. Deep to that now is this superficial fascia, also called the hypodermis, also called subcutaneous tissue, deep to that. And this is going to be where adipose is deposited. It's also going to be what helps kind of support and hold the dermis in its place. And so coming through here, you're not going to be able to see this, but there are what are called reticulocutis fibers, which are found in this hypodermis layer. And their job would be to they have projections that come from the deep fascia and then come up into the dermis. And their job would be to hold the skin in place. Have you ever noticed how your skin is pretty, it stays in one place by design? It doesn't just slop around and move. Well, think of like a basset hound, how the skin just kind of can go any which direction. Ours helps hold its shape. Now, when adipose gets deposited into the hypodermis layer, the subcutaneous layer, those reticulocutis fibers coming from the deeper layers, coming and anchoring them to the dermis, will get stretched. And if you've ever known somebody who's lost a lot of weight, sometimes you'll notice that when that weight goes away, when the adipose goes out of the subcutaneous layer, the hypodermis, now those reticulocutis fibers have been stretched out, and the skin is has a little more slack, a little more freedom to move. So that's what's going on there. Deep to the hypodermis is this deep fascia right here. It's almost like a shrink wrap around the muscles themselves. So we'll see some of that too as we move through this. And then deep to that would be skeletal muscle in this case. So that's kind of the layering system. And again, this is pretty consistent throughout the body, no matter where we are going to be cutting or removing skin. Now, when you do remove the skin, this hypodermis does release itself fairly easily. If you take a blunt probe and maybe take a forceps and hold the epidermis up, you can just separate, you can tease away some of that connective tissue, breaking those fibers, releasing it from the underlying connective tissues, the deep fascia here. So this is where you'll find a lot of that adipose that we'll be trying to maneuver around and taking away to discover what's beneath it into those deeper layers. Okay. Going through my notes here too. Let's see. Let's talk about the mammary gland. Now, some of us will have female bodies that we're dissecting, and so we'll have to share the information we get from them with the rest of the group, and likewise with the male bodies. But when we talk about the anterior thorax, we will talk about the mammary gland. One of the things we'll see here in the mammary gland is the retromammary space. Now, this is going to be behind the mammary gland. Here you can see the adipose tissue surrounding the mammary gland, the glandular tissues themselves here, and the space between the musculature and the mammary gland is this retromammary space. This is often a place where breast implants will be put in front of the musculature behind the glands, so in that retromammary space. What else can we see on this slide? The suspensory ligaments of Cooper, or what does it say here? Suspensory ligaments of the breast, or Cooper's ligaments right here. You'll see these white strands and how they help hold the breast tissue and keep its shape. This is important in just noticing the difference between a breast in youth and a breast as it ages, the older we get, the shapes of the breast will change. And it's because of these suspensory ligaments of Cooper, much like those reticulocutis fibers, when the breast tissue enlarges and there's more adipose deposited, and that is what the size of a breast is made from, is the adipose tissue, not the glandular tissue. As that happens, this breast tissue will start to pull on these suspensory ligaments of Cooper, and over time, those ligaments start to what they were short in youth, and now instead of being higher on the thorax, the breast tissue as women age and these ligaments get stretched out starts to change and becomes a little lower on the thoracic wall. So those ligaments of Cooper are here. We'll see the nipple on the front side here. You can see right here coming out of the nipple are these lactiferous ducts. If you've been grew up on a farm or in rural parts of the country, you might be familiar with milking a cow. The difference here is that a cow is just going to have one duct exiting the teat here. The difference between a human nipple is you're going to have lots of lactiferous ducts coming in. It's almost like a handful of straws coming out of the nipple itself, draining the milk that was produced in the glandular tissue. Let's see, what else do I want to say there? A lot of the females that we get in lab, many of them will be quite old, and so it's going to be maybe more difficult to tell the difference between the adipose tissue here and the glandular tissue. I think you will be able to see some of these lactiferous ducts as they exit the nipple. Also, these lactiferous sinuses is where the milk would collect before it exited the nipple through the lactiferous ducts. But it's going to be maybe a little more difficult to see the glandular difference between the adipose as these women have likely gone through menopause and the structures have changed a bit. Let's see. So we've talked about that. The areola is the outside of the nipple here. Just going through the terms, trying to find them all. The areola is an area outside of the nipple. It darkens at puberty and again after the birth of the first child. But that darkened pigmented area that's surrounding the nipple is the areola. Okay, let's talk about lymphatic drainage of the breast. The breast should drain. You can see that we're talking all these dark lines here, just kind of depicting the lymphatic drainage from the right breast in this case. Most of the lymphatic drainage is going to go up into these axillary nodes, up into here. However, some of that lymphatic drainage from the right breast in this case does travel over to the left breast. Which makes it difficult sometimes to isolate if there's a disease process. If there's cancerous tissue that happened to be in the right breast, much of that will stay on the right side, much of those cells, but sometimes those cells can migrate and it can travel over into the left breast in this case. There are also other areas here where the nodes can come into the thoracic cavity. So these thoracic nodes, as it comes into the cavity itself, that makes it really difficult to isolate if there's a disease process that started to metastasize and move into other areas of the body. So the lymphatic drainage can make that tricky. Let's move on to some of the nerves and muscles that we'll see. Let's actually start with this. As we talk about the nerves coming out of the intervertebral foramen, part of these are they'll exit and go into the thoracic cavity in three areas. They'll enter first immediately through the dorsal ramus here and entering into the dorsal portion of the thorax. And so on this right side, this is kind of a cross section, a transverse cut, a transverse section through the thoracic cavity. You can see the body of the vertebrae, the intervertebral foramen, the spinal cord being in the middle of that, spinous process coming backwards, transverse process going laterally. So this is going to come out the intervertebral foramen and innervate the posterior portion of the thorax. We'll get to that more into other lectures when we talk about, when we do more dissection on the back. We won't see any of that today. As it comes around through this costal groove, I didn't talk about the costal groove, did I? Let's go back to here for a second. The costal groove is this portion on the bottom side of the rib where an artery, a vein, and a nerve will come out and come through. There's also one on the top side, a superior portion, but there's a superior costal artery and nerve up here. But there's the costal groove is what's going to maintain that particular level's major nerve supply and vasculature. So if we go back to the rib cage here, you can see where that's going to travel out around that costal groove in that rib, kind of on the inside underneath of that rib, rather. Not in the rib, but it's going to travel around and then start innervating the lateral thoracic cavity. You can see these lateral cutaneous branches of the intercostal nerve here, and some of those are going to continue around into the anterior portion as well. So the anterior innervation and just sensation is going to come from these anterior cutaneous branches of the intercostal nerve. So posterior cutaneous branches, lateral and anterior cutaneous branches of the intercostal nerve are the three places where that will exit out of the thorax. Okay, let's go to let's see what we can find here. This is an interesting muscle called the platysma. The platysma is a skeletal muscle, but it doesn't actually connect to a bone. It's just housed inside of the subcutaneous tissues of the skin, and it's like a sheet really that comes across the side of the neck down the front. You'll see it'll have it on both sides, where it comes from let's see. Will attach from the lower part of the jaw and travel down to just kind of the fascia above the shoulder here, transversely. This is the muscle that allows you to make that grimacing face. Maybe some of you are making that face right now, but this kind of drawing the chin down, the lateral angles of the face down to the clavicles here. So that's the platysma. Let's see, intercostal nerve. Let's see if we can find that. Intercostal brachial nerve. This is an interesting one here. Let's see. The intercostal brachial nerve, actually, it comes off of the second nerve root on the cervical spine here, travels down through the axilla, through the armpit area, and then it goes towards the medial aspect, medial side of the arm for innervation. So it actually ends in the upper extremity versus in the lateral aspect of the thorax. So we might see that today, that intercostal brachial nerve coming off this way. There's a muscle here called the serratus anterior. Think of serratus like a serrated knife, being these jagged teeth coming off. This is a really interesting muscle. It actually comes from the first 9 ribs here, the lateral, kind of the body of those first 9 ribs. You can see it kind of peeking out here too, there on the side. And it actually comes up and attaches to the anterior medial portion of the scapula on that side. And you think, what in the world does that muscle do? Its job really, if it's going to move the arm, it's going to allow the arm to move further than its original reach. So if you're pushing something and you want to push it just a little bit further, more in front of you, what allows the shoulder blade to hover and move around the rib cage more laterally would be that serratus anterior. Mostly, though, I think it's used. I think it's fair to say that it's mostly used in as a stabilizer of the scapula. So if you think of where it comes from, the first 9 ribs down here, attaching to the medial anterior aspect of the scapula, you can, well, let's go back to this picture here. We're looking through the rib cage. I know I'm looking at the right side now, but it would attach from here, the anterior medial aspect of the scapula, come around between the scapula and the rib cage, and attach to these first 9 ribs up and down. So the serratus anterior is more like it's going to hold that anterior aspect of the shoulder blade to the rib cage. So you don't get what the clinical world cleverly calls winging of the scapula as it comes away from the body. That medial border would wing away from the thoracic spine. The serratus anterior right here. Let's talk about the pectoralis major and minor. First we'll look at the minor. The minor is going to come from ribs 3 through 5. You can see it right here as it comes from the 3rd, 4th, and 5th rib. And it comes very vertically, almost like if this is a clock, it'd be up towards 11 o'clock, going towards its attachment at the coracoid process of the scapula. And again, it's a funny muscle. You think, well, what is this tiny little muscle doing attaching the rib cage to the shoulder blade? And when it's not functioning well, a lot of people will have this forward shouldered posture where the shoulder blade is tipped up and forward. That we just talked about the serratus anterior, allowing that rib cage or the shoulder blade to hover more laterally and anteriorly around the rib cage. If that's the case, this is going to get very short. A lot of people clinically are going to have a tight pec minor, this pectoralis minor, because the the coracoid process of the scapula, as the shoulder blade comes up and forward, it comes anteriorly and it's going to shorten up into that pectoralis minor. This makes it difficult for the proper mechanics of the shoulder blade to hold against the rib cage. So this is often a site of tension and tightness. But it's really used as a scapular stabilizer. That's the main function of the pectoralis minor, is to help hold the shoulder blade in its one place and allow for movement from it. Let's talk about pec major. You can see here, coming from the clavicle, coming from the first 6 ribs, coming down this way, also the sternum here, and it's going to go to the greater tubercle of the humerus. You can't really see that attachment under this, but that would be the pectoralis major. And when you're looking at muscles, fiber orientation matters. What does this muscle do? It's going to attach, because it attaches to the greater trochanter of the humerus and comes from the clavicle, sternum, and the first 6 ribs. It's going to hold here and pull this towards it. So as it shortens, that's how that muscle will move. And it's going to medially rotate. It's going to turn the humerus internally and flex the shoulder. So this is a great muscle. This is your push-ups, your bench press, your flies, anything that's going to bring the greater tubercle of the humerus toward the sternum. Okay. We'll talk about nerve supply now for a minute. Well, before we get there, let's talk about the delta. We got a nice picture here of the deltopectoral triangle. This is a small space. It's actually not as easy to find here as Netter has depicted. But the deltoid here is this muscle on the outside of the arm, coming from the spine of the scapula posteriorly. This is the right side, obviously. Looking at the acromion, coming from the clavicle, the proximal third to half of the clavicle. And it's going to attach all down anterior, middle, and posterior fibers are going to come down and have a common attachment about halfway down the humerus at a bump called the deltoid tuberosity. This is going to be a massive muscle that helps abduct the arm from the body. Anterior fibers will also help flex the shoulder. Posterior fibers will also help extend the shoulder. But as a rule, this deltoid is an abductor. It's named deltoid because of its shape. It looks like the delta, like the Greek letter delta, which is a triangle. And between the pectoralis and the deltoid is this small groove here, this deltopectoral triangle, or the groove where the cephalic vein is going to be found. The cephalic vein, again, this is a generous picture. It's not this obvious as it comes between here, but it's going to empty, it's going to drain some of the blood supply from the upper extremity into the axillary vein before it enters into the subclavian vein, and then ultimately back in towards the brachiocephalic vein, back into the heart. Superior vena cava in this case, back into the heart. But anyway, the cephalic vein comes up from the arm and then will travel up, will come up from the lateral aspect of the arm up into the axillary vein. A couple of nerves you'll see as you dissect down and take the skin off here. So as we cut the pectoralis major off, as we kind of remove this and make it flap out of position, you'll get to this position here. So you can see the pectoralis major has been cut right here. And then once that's removed and you can see deep to it, you'll see that pectoralis minor. You can see underneath this fascia here. But here's a couple of important nerves, the medial pectoral nerve and the lateral pectoral nerve right here. The medial pectoral nerve is responsible for innervating the pectoralis minor muscle. Okay, it's going to pierce right through the pectoralis minor and innervate both the pec minor and the pectoralis major muscle. And so that's going to be motor innervation to both of those pectoralis musculature. Now the lateral pectoral nerve is just medial to the medial pectoral nerve. Now you're thinking, wait, no, I know medial is towards midline, lateral is away. Why is this the medial pectoral nerve and this is the lateral pectoral nerve? The reason is because it's not named for where it is on the thoracic on the anterior thorax. It's named rather from where it comes from within the brachial plexus. They're named for the cords that they'll arise off of in the brachial plexus. So the lateral pectoral nerve comes off the lateral cord of the plexus. The medial pectoral nerve comes off the medial cord. But it is a little confusing if you look at it anatomically and you think that's not the right orientation. You're right, but that's why they're named that way. Now the lateral pectoral nerve is found medial, like I said, to the lateral pectoral. So the lateral pectoral nerve is found medial to the medial pectoral nerve. Boy, that becomes a mouthful if you say it too much. And it's responsible for motor innervation to the pectoralis major only, not the minor. So the lateral goes to the major, the medial goes to the minor, and the major of the pectoralis. Let's see here. Let's talk about the subclavius muscle. The subclavius, you can kind of see it peeking down right here, is coming from the clavicle here to the first rib. That's where it's going to attach, from the clavicle to the first rib. Very short muscle, and it's a massive stabilizer again to the shoulder joint itself. Because remember, the clavicle is the only bone-to-bone attachment of the upper extremity and the shoulder girdle to the skeletal system. Any stability you can have is always appreciated. And you might wonder, well, why isn't this just a ligament? Why can't a ligament just connect that bone to that bone and help stabilize it? Because that's the ligament's jobs as well. And the answer is because it needs to stabilize the shoulder by in way of the clavicle as the arm moves. If you think of the arm here, reaching up, reaching further, higher, the clavicle needs to hinge at this SC joint, kind of pulling up higher, and that muscle needs to allow that, needs to be able to stabilize the shoulder in multiple angles of where that shoulder is in space. So that is why it can't be a ligament and how that musculature can work there. We'll talk about the axillary artery. You can see kind of coming out here. When we see the heart, the first branch off the arch of the aorta is the brachiocephalic artery going towards the right side, which will become the subclavian artery as it goes underneath the clavicle, under clavicle, clavian. So the subclavian artery, as it exits the clavicle, but before it gets to the humerus, this little space here is that portion of that artery which is the axillary artery. You can see it here too. Before the clavicle's gone here, so you can't really see where the subclavian becomes the axillary. But before that, after the clavicle and before the humerus is where that will be the axillary artery. That will then continue on to be the brachial artery into the upper arm as it goes through. The thoracoacromial artery, you can kind of see as it peeks down through here, and that's going to be a major one to supply the pectoralis major and minor musculature as it comes off of the axillary artery. It's going to supply blood supply to the pectoralis major and minor, also the anterior portion of the deltoid as it comes down. So that's one that we might find in our dissection today. And then this last one we'll talk about here is the lateral thoracic artery. This is an important one on the outside, coming, again, branching off of the axillary artery in the armpit, coming down the side of the thoracic wall this way. So you can see that here. Well, I think that's probably enough talking. We'll see what we can find in our dissections today. I hope you learned something from this, and I will look forward to talking with you again.